There will be case presentation of 4 minutes duration, followed by 6 minutes discussion. So in this episode 1, we have taken cases from Retina, and we have expert panel today with us, including Dr. Mahesh, Dr. Gopal, Dr. Divya Balakrishnan, Dr. Prakash, Dr. Rajesh, and Dr. Manoj. Dr. Divya M. Nair, Dr. Kiran, Dr. Pradeek, Dr. V.S. Anchita, Dr. Shishir Varghese, and Dr. Indu Nair will be presenting cases. With this short introduction, I hand over the program to Dr. Gopal, who will be moderating the session today. Over to you, Gopal.
Thank you very much, Dr. Baston. It's a very thoughtful program in which we will be discussing some X-files, some not so common cases. Maybe it may look common on the outset, but on investigation, we find out that beneath the surface, there is a layer of mystery. Okay, so this will be 1 hour of sweet program in which we will have a wonderful panel with me, including Dr. Mahesh, Dr. Divya, Dr. Prakash, Dr. Rajesh, and Dr. Manoj. So I look forward for an excellent discussion. I'll call up the first speaker without any delay. Dr. Divya, you can present your case. It will be a 4-minute presentation, 3 to 4 minute presentation, followed by a 6-minute discussion. During the presentation, please, I request all of you to keep muted. Divya,
Thank
please.
you, sir. I hope I'm audible.
Yes, you are.
Okay, let me begin with my case presentation. I thank all of you for this wonderful opportunity given to me. So this is about a 49-year-old male who presents with sudden decreased vision in his left eye since the past 2 days. He also gives us a history of past recurrent episcleritis for the past 6 months. At present, his vision is 6/6 in the right eye, but in the left eye, it has become 6/60 and it is N12 in the left eye. The anterior segment was within normal limits. And on just a cursory fundus examination, the fundus actually looks very normal. But on closer examination, we saw that there is a little bit of vitritis in both the eyes, and there are subtle RP changes in the macula in the left eye. So because of the vitritis, he was a routine uveitis workup, blood investigation was also prescribed. We did an autofluorescence, and to our surprise, in the asymptomatic eye, that is the right eye, area of placoid hyper AF lesion is seen at the posterior pole with well-defined margins. In the left eye, also a little hyper autofluorescent lesions are seen in the posterior pole. The infrared imaging, the right eye is actually looking normal. In the left eye, we can see small hyperreflective dot lesions surrounding the fovea and the macula. OCT shows intermittent disruption of the ELM and the ellipsoid zone in the right eye. And in the left eye, these changes are more profound. There are more hyperreflective dots. The RP is more irregular. And corresponding to the IR image, the hyperreflective dots are also seen in the RP level. There are hyperreflective dots even in the level of the choroid and choriocapillaries. An angiogram was done. An angiogram in the right eye showed a hot disc and with hyperfluorescent leaks in the pinpoint leaks in the late phase, mainly involving the posterior pole. In the left eye, the angiographic images are more dramatic. There is a more hyperfluorescent lesions with leak. There is perifoveal leak. There is a distinct hot disc seen. And if we compare the IR image and the FFA in the hyper-reflective dots, which were seen in the IR image, is seen as block fluorescent dot-like lesions in the fluorescent angiogram. This is persisting even in the late phase of the angiogram. Octa showed reduced vascular density at the level of the choriocapillaries. And in the right eye also, nodular areas of flow void were seen in the level of the choriocapillaries. The blood investigations were now there, and we saw that VDRL and TPHA have come positive. HIV is negative. Most of the other rest of the investigations are within normal limits. So empirically, he was just started on doxycycline, and he was asked for a physician consultation for systemic evaluation and also to start on penicillin injection. He, however, came back to us after 2 weeks, and his vision had improved to 6/9, and it had become N6 in the left eye. We were actually planning to do some field test or something if the complaints still persisted. And the repeat OCT and autofluorescence was done. The OCT actually shows that the ellipsoid zone and the ELM integrity has become better. The autofluorescence also shows changes. The right eye, which had a well-defined hyperautofluorescence, has now become diffuse and lighter. In the left eye, however, the hyperreflective dots have become more prominent now after 2 weeks. So we were puzzled whether this is the acute syphilitic placoid chorioretinitis with a spontaneous resolution which we are dealing with, or is it something like Mudes or Azure in evolution? Thank you.
You can stop sharing your presentation. Clinically, you felt that there is no, I mean, retina looked normal, but
Yes.
autofluorescence definitely showed us a lot of changes.
Lot of changes.
The RAPD was not there. There was no RAPD.
No RAPD.
Nothing. Okay. To my expert panel, let me ask Divya first. So Divya, what do you think? Usual for syphilis to present. What is the age of this patient?
49 years, sir.
Yeah, 49-year-old patient with just a retinal pigment epithelial outer retinal lesion, or will there be multiple retinal vasculitis or things like that? What is your common presentation of syphilis?
Sorry. Syphilis actually is one of the biggest masquerades, in fact. So it can present in any way. So it can present like, but this patient had a multiple episodes of episcleritis also earlier.
Yeah.
Yeah.
At
And
that time, it was not investigated at that point of time.
Okay, and that OCT feature and even the auto, maybe because that was a multicolor picture. I think I don't know whether it was true color
Because multicolor picture.
Multicolor.
Yeah, multicolor. So if it was the normal fundus picture, maybe I think that we could have better appreciated those changes, like because this has typical that edges of that how you see in a placoid. Typical posterior, and the OCT actually that if you can show that OCT, that RPE changes, that is very typical of syphilitic changes actually.
And Divya, you can just show the OCT once again. Yeah.
And the patient was strongly positive for TPHA, and he improved with penicillin, right?
Penicillin was not started, ma'am. He just improved, like empirically only doxycycline was given and he was sent for physician. So
Okay.
by the time he came back, he's already improved.
But was he on doxy?
Yeah, he was taking doxy, he was taking. Yeah.
Okay. Any high risk behavior or anything like that in his?
Not we could get from the history even after asking, but we felt something was suspicious. That's why both VDRL and TPHA was also sent at the first instant.
Yeah, it is important that VDRL may come positive at any point of time. Like he had syphilis, VDRL will come positive. You have the pre and the post OCTs. No, these are.
They are pre ones.
Yeah.
How
The
long
left eye,
was given?
2 weeks, ma'am.
2 weeks. Okay.
But generally, if there is a syphilis, we would consider penicillin, penicillin itself, right?
But this was sent for the physician. In the meantime, we just started.
Gopal, can I add on 3 points?
Please, Rajesh.
See,
Please.
actually, I have seen this patient. So the reason why we started penicillin was that sometimes this patient do not go to any physician at all. So it is always safe to start the patient on doxycycline and then send the patient for penicillin injection. Then about what Divya said, there was nothing on fundus examination. Even if you had taken a normal true color image, you would not have found out anything there. There was no plaque. So this is one condition that has been described. In addition to the typical confluent retinitis as well as the placoid retinitis that is described in syphilis, there is a third entity which is known as a syphilitic outer retinitis, where you don't have anything on fundus examination. Fundus examination will be absolutely normal. Only the FAO will show this hyperautofluorescence. That is
but in
reason.
Rajesh, in view of this hot disc, this disc is significantly leaking. Do you also think that optic neuritis may have been there in this case? A secondary, infective optic neuritis.
And also, I think there's some trivial vasculitis also.
Yes. There is some amount of vasculitis also.
No, but the 6/60, if you had the optic neuritis plus the macular pathology, then we would explain that. Any further? I mean, last comment, Mahesh.
No, I was just thinking why that syphilis was thought about. I would have just imagined it is a mutes and a pigment epitheliitis. Fantastic. You have seen similar cases before. I have seen only one syphilis in the last probably 10 years. So I don't know. Why was syphilis suspected? TPHA is part of the investigations that you give, Rajesh?
Mahesh, that is a very good question because actually,
Uh,
I also was thinking about mutes only in the first instance. It could be
Now,
mutes which are flex.
left eye looks like mutes. Right eye has pigment epitheliate. Yeah, mutes pigment epitheliate is that spectrum.
It clinically looks more like a mutes patient only. But then, in the meantime, the patient was seen by another doctor who had actually sent for all the workup of syphilis, for the entire workup of uveitis. So that is how
Okay.
the patient came positive. That is how we came to the diagnosis. It was an accidental diagnosis.
One point against mutes could be that this is bilateral. Mutes is generally
Yeah.
Unilateral.
this is a male patient,
And 6/60 is a little significant drop in vision. Mutes does not have.
I think your OCTA which showed that there are some hypo in the chorea capillaries. So that also seems to be against mutes.
Mutes again.
Typically, the chorea capillaries are not affected. So
May I
Okay.
ask something, sir? May I ask to the panel? Should we evaluate for neurosyphilis in these patients? Like if the ocular syphilis is there?
yeah, I think so because if you're thinking of a placoid syphilitic lesion or like even outer retinitis is usually a part of the secondary syphilis. So I think neurosyphilis should be part of the evaluation. Evaluation for
Yes.
neurosyphilis should be part.
Yes, all is well that ends well. As Divya said, syphilis is a greatest masquerader. TB is something that we have seen more often. Syphilis was a little before that age, but now there is a resurgence of syphilis. With this, we'll move to the next case. Thank you very much, Divya, for this wonderful learning opportunity. We will have Dr. Kiran KR presenting to us his case. Kiran, you can click on that right top where you see that you can click on the right side top and that presentation will come. No, this is your image. There is a presentation which you can click on. You can stop sharing and reshare again. You can stop share. You can stop sharing in your computer. Just open the presentation and keep. Welcome, Prakash. In your presentation, you open your presentation and keep in the, and then now share it again, please, and share your screen. Are you sharing? Yeah, you can present like this. You can go to the next slide. Yeah. Kiran, are you muted? We are not hearing you.
Kiran muted alla, പക്ഷേ we can't hear you.
Yeah, Kiran, you can send me the presentation. Kiran has some technical difficulty, so what I will do is we'll have Dr. Pratik go and present the next case, and Kiran can send your presentation to me. I can present from here, but your voice is not. We are not able to hear your voice. you please correct that. Okay. Yeah. Pratik, you can present your case, please.
Yes, sir. So are the slides visible?
Yes.
First of all, a very good evening to all the members present. So I'm going to present a case of a 50-year-old person who was referred to us with history of gradual decrease in vision, right more than left eye, with history of hypertension. Other relevant histories were recurrent renal stones, multiple renal surgeries, history of partial nephrectomy status post-infection, and arthritis. This was the presenting fundus picture of the patient. Vision in the right eye was 6/60 and left eye 6/12. Anterior segment was within normal limits in both the eyes. On examination, there was crystalline deposits throughout the retina and concentrated in the arteries. There was narrowing of the arterial tree. Then other than that, there was concentration of cotton wool spots and multiple hemorrhages on the posterior pole. There was few exudations at the macula. This is the infrared image of the same patient in which we can see the crystalline deposits more clearly in the arterial tree and at the level of retina. The OCT image was not very clear because the patient was very sick and unable to sit properly on the OCT machine. However, we saw a few cystic spaces and hyperreflectile dots in the inner layers and few at the level of choroid as well. In view of systemic instability of the patient, FFA was deferred and a full systemic workup was advised in view of crystalline retinopathy and ongoing ischemic signs. On nephrology workup, the patient had CKD stage 4. He was diagnosed with primary hyperoxaluria type 2 with gene mutation, and synovial fluid also reveals oxalate crystals. At presentation, serum creatinine was 6.6 with very high serum oxalates and deranged KFT. Patient after 1 month presented with further drop in vision in the right eye, which dropped from 6/60 to 4/60. The left eye, the vision was maintained. At this time, we were planning on the OCT. You can see the arteriole can be seen in the inner layers with hyperreflectile dots all along it. On this picture, the same features that we had highlighted as before. We went ahead and did the FFA since we were planning to put the patient on hemodialysis. There was significant delay in the arm retina circulation time and AB transit time. There was significant global ischemia, disc leak because of NVD, and marked posterior segment ischemia. The patient then again came after 2 months. At this time, he had an acute drop in right eye vision. He was already on regular hemodialysis, and there was systemic deterioration with pleural effusion. This is the picture. 2 months after the initial presentation, we can see this development of NVD, vitreous hemorrhage, worsening of the ischemic signs. Left eye, his vision dropped from 6/12 to 6/24. The patient was advised to undergo right eye ranibizumab followed by both eye panretinal photocoagulation, where patient was able to maintain his renal status over the next few months. This is the status after his injection and PRP both eyes. For 4 months, he was able to retain vision of 1/60 in the right eye and left eye 6/60. There was significant macular ischemia in the right eye. This is the OCT angiographic picture of the patient, which shows absolute decrease in the capillary and superficial vascular network in the right eye. 8 months after the initial presentation, the vision starts to drop in the left eye. At this time, he's already on hemodialysis. His renal status is worsening. His pleural and pericardial functions are also worsening. This time, he's planned for renal transplant. This is the picture 10 months after the presentation. Right eye, the neovascularization and disc has again increased after being regressed for a few months. Left eye shows NVD with bleed. If we see this chronological deterioration, we can see as the serum creatinine and oxalates are worsening, so is his clinical status. This is his final follow-up with us. The patient is 2 weeks after his renal transplant, is maintaining his vision 1/60 in the right eye and 4/60 in the left eye. There's increase in the crystalline deposits since the initial presentation, significant attenuation of both arteries and veins at this point. So the diagnosis was retinal oxalosis with ocular ischemic syndrome with primary hyperoxaluria type 2. It is a rare disorder, so we don't have any well-defined guidelines whether we should only go ahead with the renal transplant or do a combined renal and liver transplant in such a patient. In our case, there's a relentless progression of global retinal ischemia that led to neovascular complications. And despite regular hemodialysis, he kept on worsening. And I want to ask the panelists that what can we offer to the patient other than managing his neovascular complication at this time? Because despite his renal transplant, since the liver is not functioning properly to metabolize oxalate, it will again deposit in the new graft and lead to an allograft failure. So, any suggestions from the panelists?
Yeah, can you rewind the presentation? Yeah. Anybody wants to take it? Manoj?
I know this is a difficult situation. I think generally patients with this primary oxalosis, they end up with poor outcomes. And the only thing that is surprising in this patient is the patient actually, is a little older. No? He's 50 years old. Usually patients are a little more younger when they present with this pattern. But otherwise, I think there's nothing more to offer. I was just thinking that after the first examination, we should have gone in for an early PRP in that eye. I mean, the patient presented 2 months later. But anyway, if you look at the left eye, in spite of the PRP, that eye actually PRP and anti-VEGF eye progressed. So I don't think we could have done anything better in this situation, because the pathology is as such where progressive occlusions can happen. Is what I
This
see.
is just throwing light to a new pathology. Like if we are seeing the vasculature and the amount of hard exudates and soft exudates that the patient presented with a creatinine of 6.6, we would definitely think in terms of a mixed diabetic retinopathy, hypertensive retinopathy thing. But the point here was along the blood vessels, there are multiple crystalline deposits. So when there are deposits along the blood vessels, Prakash, what all will go through your mind when there are multiple vascular deposits?
A very interesting case actually. This is an eye opener. I think we would have never thought of oxaluria as a cause in this, because I have not seen a case like this before. But what other things, if you think it's mostly whenever we see a crystalline study, we think of tamoxifen toxicity or Beatty's crystalline degeneration or even cystinosis. Cystinosis also, when the systemic syndromes are there, we would think of cystinosis. These are the things which will go through your mind, but definitely
sometimes even emboli can be. Sometimes even emboli can be.
Talc can be. I have seen a case of talc where
Yeah.
a drug injecting patient has come with multiple refractile particles inside all retinal vessels. So that is again a possibility. So these are things which will go through your mind, but this definitely. And as regarding management, what I think is there is definitely signs of ischemia worsening. So there is no harm in doing maximum PRP. There is still gap, I think, in the thing, because mostly it is retinal ischemia that is causing the problem rather than a carotid disease or something. So we can do maximum PRP in this case. Still additional PRP and even an anti-retinal cryo and all those things can be done to reduce ischemia as much as possible.
Yeah. I think for want of time, basically we understand.
Gopal,
Please.
this actually the clinical finding has two parts. One is crystalline retinopathy and crystals in the other quadruple spot and hemorrhage probably are due to nephropathy and hypertension and all this equally. Maybe. So just one question, because I am also seeing for the first time. Will it cause other end organ occlusions like a stroke and MI or anything like that? I don't know. I'm just asking you.
Sir, this patient had multiple deposition in joints, kidney, other than kidney, even in pericardial area, when we did a CT, there was depositions. So his multiple organs are failing. That is why he was a very sick patient. Even despite regular hemodialysis, kept on falling.
Yeah, because the cause is not corrected now, only that. Yeah. Okay, thank you. Nice.
One caution should be like it is reported that when people are on vitamin C therapy, these situations they may have vitreous hemorrhage or pre-retinal hemorrhages, and sometimes we tend to give vitamin C. It's not a good thing to give in these patients, because that will aggravate the clinical thing. One should also ask history of any GI surgery, because sometimes the malabsorption syndromes can actually worsen the presentation of oxalosis. Yeah.
Yes. Thank you.
Okay. Thank you very much, Pratik, for that enlightening case. Let us move to the next case by Dr. Anchita, V.S. Anchita. Don't miss the forest for the trees. Anchita, you can unmute yourself here. Please share your presentation.
Okay, sir. Very respected. I thank for this topic. I will 45-year-old man from he's an old chemical plant, and his present complaint was addiction and total deprivation. And nothing relevant in the personal and family history, and partly relevant except using drugs for the past 10 years.
No?
Sound is breaking and not seen.
So
Reshare it,
For me
please.
also.
yeah, Anchita, can you off your video? Can you
And
off
put
your
on
video?
slideshow.
Yeah, and click, yeah.
Now
You
sorry.
can-
Now it is the yeah.
Now you can continue, please.
Yes, am I visible, sir? Visible, audible?
Yeah,
Yeah.
continue.
Yeah, you can start from
sir.
first slide.
Can you start from the first slide, please?
Yes, sir.
Anchita, you can off your video.
Sir.
You can off your video. That will save some bandwidth. That will improve your audio.
Yeah, okay. Now presenting complaint you can see. Continue.
The 55-year-old man, he presented with blurring of vision floaters in his right eye of 2 weeks duration. And his past history was irrelevant, except for he was using glasses for the past 10 years. So my
Slide is not moving.
Can you move your slide, please?
now it is okay. Sir.
Yeah, now it's okay.
And his personal history and family is nothing relevant in his history. And coming to occlusion, his best corrected vision acuity was 9 parts with plus 0.75 diopter sphere. And in left eye, the vision was 6.6. And anterior segment examination of both eyes were within normal limits. And fundus examination revealed a hemorrhagic PED at the macular region with submacular bridge. And we can see yellowish lesion seen supranasal disc. And fundus examination of left eye was within normal limits. And with the provisional diagnosis of right eye polypoidal choroidal vasculopathy with a choroidal mass lesion, right eye hypermetropia, and both eyes presbyopia. We went on to the investigations. Both ophthalmic and systemic evaluation were performed. And ophthalmic evaluations, OCT and FFA, and fundus autofluorescence was done for this patient. And OCT imaging, OCT macula showed an incomplete PVD and an elevated fovea cone too, and normal neurosensory retina. And here we can see a subfoveally a submacular hemorrhage is seen, and a notch PED is seen nasal to the disc. And OCT through the choroidal lesion revealed loss of the chorea capillaris layer from outer to inner, loss of chorea capillaris, and a hyporeflective dome-shaped elevation of the RP is seen with overlying subretinal fluid. And there was elevation in the choroid, and we suspected a choroidal mass lesion. And UPTA was done with the patient, but due to block fluorescence, the vessels could not be delineated properly. And OCT and on first image showed clearly it delineated the PED and the submacular hemorrhage. And FFA was done for this pit. And here we can see the early, mid, and the late phases. Towards the late phases, we can see stippled hyper and hypofluorescent areas corresponding to the RP changes. And fundus autofluorescence showed hypo and hyper autofluorescent areas corresponding to the RP changes. And we came to the diagnosis of right PCV with choroidal mass lesion, likely choroidal metastasis, and right hypermetropia and both eyes presbyopia. And systemic evaluation was with normal limits. It was done and was within normal limits. In view of the macular pathology, the patient was administered intravitreal and SF6 was given in the right eye in February, and nothing was suspected of any underlying systemic abnormalities, and systemic work was advised solely based on the choroidal metastatic lesion, choroidal mass lesion seen in OCT. And we referred the patient to an oncologist, and a whole body PET MR imaging was done, which revealed a left lower lobe malignancy with subcarinal nodal metastasis. And there was also a left third posterior lesion, which was also likely to be metastasis. And fiber optic bronchoscopy was done, and linear endobronchial ultrasound done. And the cytology, bronchoscopic biopsy revealed adenocarcinoma. The features were suggestive of adenocarcinoma lung. And later, on ophthalmological evaluation, the patient developed a right eye rhegmatogenous RD with macula O, and there was a supratemporal horseshoe tear noted with choroidal mass lesion. And via surgery was done, and the vitreous sample was sent for cytopathological examination in March, and the cytology was found to be negative. And later, the patient underwent 4 cycles of chemotherapy with pemetrexed and carboplatin. And later, CCT test was performed for reassessment, and patient was stable. Then radiotherapy was given in 5 fractions, each to the left lung lesion and the left third rib lesion. And a maintenance. Now the patient is on maintenance chemotherapy. He has already taken 3 cycles, and he is advised 2 more cycles. So here, what the patient presented with polypoidal choroidal vasculopathy like presentation, but actually it turned out to be a choroidal metastasis, and underlying malignancy was found out. That is primary adenocarcinoma lung was found out. So never miss anything. That is, we should not be carried away by the initial presentation of the patient or the pathology behind the initial presentation. And a whole eye should be examined properly, and we should look into the systemic evaluation as well. And we may be the first persons detecting a malignancy.
Thank you very much,
which will
Akshara.
be,
Thank you very much. You can
thank you
stop
so
sharing your presentation. Very uncommon to have a submacular bleed as a part of metastasis, right? Who wants to take this?
That is different. That is different etiology. There is no
Yeah,
doubt.
two
That is a
etiologies.
PCV, 2 etiology at a same eye. Actually, that is a classic PCV with the subretinal and sub-nose to PED. Everything fits into PCV. Classic. The other one is a different etiology. There is no connection between that. Nice workup.
ഇടിവെട്ടേറ്റവനെ പാമ്പ് കടിച്ച ഒരു പ്രശ്നമാണ് അല്ലേ?
The only thing is that HST might have been, what is the cause for reg-RD? Because metastasis will not cause reg-RD. And probably post-injection, some PVD induced or something like that, maybe.
Yes. Post SF6
Maybe,
injection,
maybe.
there may have been a PVD induced.
Now,
right?
one thing I would suggest is like when you had that choroidal elevation in the first visit itself, you should have done an ICG also in that case, actually. Other than just an angiography would not have been sufficient. And again, OCT through the other other lesion also would have given more information, I feel.
Divya,
Why
you
it
can
is not an
probably-
osteoma? Why it is not an osteoma in clinical picture and angiography and OCT?
Yeah,
So
actually,
that shadowing is not there, I think, that kind of like an
I
osteoma.
think it's not a well-defined. It's yeah, probably.
actually, the clinical picture was looking in terms of either like a lymphoma can present something like this, or even Mets, or as you mentioned, actually, even osteoma can also give such a picture, actually. But the OCT, when we did, the lesion was exactly in the choroidal, and it was like a well circumscribed lesion in the choroid. Lymphoma, usually, choroidal lymphoma is very rare, actually. So if you see, usually you will see the deposits in the subretinal plane. This was in the choroid, and osteoma usually will be little more linear, lamellar kind of thing, and more hyper also. So
My
that
first
is,
diagnosis was like choroidal granuloma with a secondary CNVM, probably because it's a choroidal granuloma also is seen, and the CNVM is their typical location adjacent to it. So that's
No, but it is
tubercular.
not adjacent. No, Prakash, it's a little away from the yellowish lesion. Yeah, it's a little away. So as Mahesh said, if we are able to, think about two different diagnoses, one a MET and other one a PCV, then there is nothing in it. It's only that for the patient, it came together in a
Too
very
much
bad
coincidental,
time.
no, Gopal?
Yeah, I think, Divya, do you think that the hemorrhagic PED, you have been the physician who probably looked into the case. So, do you think that the PED, the hemorrhagic PED is related to the metastasis? Or they are, like
Thing
Mahesh
is,
said, two different
even I was looking at the literature because I have one more patient who actually even maybe what I missed was an ICG because I did not have a good ICG. That was the reason why did not do an ICG. I had a similar patient that was a lady, but she was having Crohn's disease or something which she was getting treated. She presented like this. I could not get a definite network, or even in the FFA did not show any leakage. But it was similar to a submacular and hemorrhagic PD. 2 months later, down the treatment, she was lost to follow-up. And 4 months later, she presented with a diagnosis of CA breast. So, but that lady did not have any choroidal mets or anything like that. But so I was just looking at the literature, if anything is there which is having some connection or is just a coincidence. But I could not find anything. This is my second patient whom I am seeing like this.
Generally, in the
like
setting of
choroidal melanoma and all not to cause secondary CNVM. So METs also can cause secondary CNVM, I think.
But
Manoj,
METs usually come into the eye, usually in the late phase of a cancer, when it is near the spread into the cerebral area, etc. So that is a point of time where people do not live long after that. That is why we probably don't see a lot of METs going into choroidal neovascular membrane, etc. Dr. Thomas is here. Dr. Thomas Chiran, our president. Dr. Thomas? Yeah.
Yeah, Gopal, I'm here.
Yeah. So, do you think that, post SF6 pneumodisplacement, is there a higher chance for a retinal tear, retinal detachment, PVD, etc.?
Yes, that's exactly what I feel. This patient might not have had a PVD earlier on, and after that pneumodisplacement, sort of a violent PVD developed, causing a horseshoe tear and a rhegmatogenous retinal detachment.
Here, pneumodisplacement was done, or only anti-VEGF injection was given?
Yes.
Both.
Along with the anti-VEGF injection, and the horseshoe tear and retinal detachment developed later on.
Yeah. No. In this case, actually it is not subfoveal. It is just below the fovea. I don't know. It's a difference of opinion. Pneumo is really indicated. Small size, only 1.5 disc diameter. It is eccentric to the fovea. Where are we displacing? So, just a point of discussion for the PCV part. Otherwise, it is subretinal. It will displace well with the gas. That I agree.
Can I make a comment?
Yeah, sure.
No,
Last comment.
I think from the OCT, that lesion in the macula looks like a PED with a rip. That is how it looks like. So most likely, that is not related to the to the malignancy part is what I feel. Second, generally METs, they have some amount of fluid. The fluid is a very important characteristic of METs. This patient did not have fluid, but it's quite possible that at the very early stage,
some amount of fluid was there. I think
it was there.
It was there. Some amount of fluid was there.
Otherwise, the OCT was typical of METs. The surface was like a irregular, smooth, and I think it was in favor of a METs or even choroidal melanoma. That was amylotic melanoma.
Okay, so we have a case of kyphosis over scoliosis, or scoliosis over kyphosis. Anyway, let us move to the next case. Shishir
Am I
Varghese.
audible, sir?
Yeah, Kiran, we will take your case last.
Okay.
Shishir Varghese will present on brodusumab, the double-edged sword.
So, can you see the screen?
Yes. Brodusumab is the new drug, which has a lot of very good efficacy and duration. Now let's hear you. Yeah.
So thank you, KSOS, for this opportunity, and thank you, Dr. Gopal, for the invite for this presentation. So I'll be talking about brolucizumab, the double-edged sword. So this was a 46-year-old female with decreased vision in the left eye since 5 days, and right eye was 6.6, and left eye was counting fingers 1 meter. She was hypertensive on meds, no trauma, and anterior segment was unremarkable. So this was the fundus picture. The right eye was absolutely normal, but the left eye, as you can see, had a hemorrhagic PED, subretinal fluid, subretinal hemorrhage, and also a large serous PED just temporal to the fovea. And this is the autofluorescence. The right eye is normal, and the left eye is, you can see the blocked autofluorescence due to the hemorrhagic PED, and then multiple changes in the RP as well as a hyper area, which is corresponds to the area of the serous PED. So this was the OCT line scan through the fovea, and we can see subretinal hemorrhage, subretinal fluid, as well as large notched PEDs with a double layer sign. And then there was this large PED there, just superior to the supranasal to the fovea, adjacent to the disc there with hemorrhage. And another area of a polyp was confirmed on the OCT angiography, which we did. So based on these multimodal imaging, we diagnosed as polyp or PCV, and then gave 3 doses of Paginax, actually 2 months apart. So this was 8 weeks apart. Each dose of Paginax was given, and she had a really good response actually. So this you can see after this is the OCT from counting fingers 1 meter. She is improved to 6.9 after the 3 doses with complete flattening of the PED and as well as the disappearance of the almost disappearance of the double layer sign. And so now the plan on her was, I thought I'll just go ahead and do a small focal laser there to that polyp, which could, because PED had completely flattened. And then post the 3rd dose, after a week, she comes back with mild tenderness and redness and complaining of floaters. Her vision was still maintained at 6.9. And then when we see the fundus, we can see that in the left eye, now she has got a little bit of a disc edema there, and the PCV is starting to, come back. This little bit of a hemorrhage, which has started again there. So disc edema there. So yeah, so that's a line scan through the disc, and you can see the disc edema. Now there are vitreous cells also. And although the PCV is still, flat, and this was the OCT RNFL, which showed the disc edema in the left eye. So, got scared a bit and sent her for MRI also, just to rule out a concurrent optic neuritis, which the MRI was absolutely normal. And this was post-treatment with topical, subtenon, and oral steroids. And the disc edema had resolved after a period of 3 weeks. And vitreous cells had also reduced significantly. Disc edema had also reduced, but now the PCV is starting to act up again. I did not do the focal laser. So PCV is starting to, become active again. At this point, I could not offer her any Paginax or anything. So I just went ahead and treated her with Eylea. So as you can see the review of literature, there are multiple studies on brolucizumab causing intraocular inflammation. And there is also reports of, disc leak, which has been described, but disc edema per se has not been described in literature. And now even in this new study in done by the Indian VRSI group, that also shows 0.7% of inflammation in the, due to Paginax. And there also the spacing between the injections was 2 weeks apart. So to conclude, so exercise caution while using brolucizumab, more spacing between injections, and adverse effects has already been described, but disc edema is the first I have to report in literature. And the PCV management, it requires more frequent injections, but the ideal treatment is with combination therapy. Thank you.
Thank you very much for highlighting the importance of caution, exercising caution while using brolucizumab. I can stop sharing the presentation. So all of us have had some problems with brolucizumab. Yeah, Mahesh, you go first. You wanted to talk. Yeah.
Actually, this mild vitritis and all is okay, but I had a severe vasculitis with after 4th injection after 5 days, all sclerosed vessels and infarction in the macula. Uh, so and that also some 50 plus. I don't know. The only thing that across the patients, they are all quite young, not 70s, 80s. This is one thing that I understand. It's absolutely difficult to predict who is going to get it. Okay, that is first thing. Because after first injection, second injection, third injection, fourth injection was given after 6 months. with a gap of 2.5 months gap. So it's not possible to predict who is going to get, when it is going to come. So this reason, Bromab has been used less and less across the world, and only as a last resort when other things are failing. There is another study or some presentations where they give along with brolucizumab little subtenon steroid also, so that it will take care. That is one other method some people are practicing, but we are not having dearth of, anti-VEGF injection. Now there are a lot of molecules. So very, very difficult to predict. Very difficult to predict. I will present that later. Thank you.
Shishir, you wanted to say something?
I've started giving, after this case, I've started giving Predfort for all brolucizumab
Yeah,
patients.
yeah. Actually, last 1.5 years, I am giving a steroid antibiotic combination for a couple of weeks. That almost everyone is giving. Everyone is
No,
giving. In fact, I asked a lot of
but the steroid antibiotic combination and predacetate can only take care of very, very mild cases of
Agreed.
nephritis.
Actually, most
But
of the
the cases,
I know, actually, Gopal, the most of the cases are mild vitritis, mild uveitis. This 0.7% in Indian VRSA study, most of them, except one or two, which were severe. So this probably draw topical, and many of them are controlled with the topical medication only. So just to prevent, that's all. So severe is very rare, but very difficult to.
yeah.
If
I have one patient.
If you look into the literature, it appears that this vasculitis and arterial occlusion and this grave posterior segment inflammation happens in those patients who have some kind of mild anterior uveitis at their initial visits. So these people are more predisposed to develop later posterior segment involvement. So it is possible that with even I use loteprednol in these patients. Maybe before we started, before I used loteprednol, I had a few cases of posterior vasculitis and uveitis. But after I started using it, I have not had any episode. So I believe that maybe this bringing down this anterior segment inflammation at the initial visits may help in actually decreasing these posterior segment manifestations later on. Second, I think Shishir's case, disc optic neuropathy has been reported. There are at least 2 or 3 articles where there are 5% of these patients can manifest with optic neuropathy, clinically obvious disc edemas, and that has been reported. And now you have not shown angiography, so maybe if you have done an angiography, these patients would have some amount of vasculitis and disc leakage, which are part of the complications of brolucizumab.
Can I ask you one question? Do you actually give loading dose with the Pegenex? Or do you give injection and wait for the response and then treat on a PRN basis?
Yeah, I'm
Because
doing
we
PRN
good
from the
response
start.
even with one injection.
Yes. And generally, all the patients whom I have initial good response with Pagenex, because I also had 3 cases of inflammation. And so slowly now, after the number of cases, now I have a slight problem to continue with Pagenex. So Pagenex is reserved as a drug. When there is a problem, then we will use it type of situation.
And again, once you have an inflammation, when you switch over to another anti-VEGF, you're still bound to have some inflammation. You can have cross inflammation, even though Eylea is safer in terms of inflammation. You could still have. I've had a patient where we have switched over to Eylea and then had an inflammation after Eylea also.
One more point I want to bring out in Shishir's case, patient's vision at start was 1/60. With hemorrhage, it was a very badly looking macula. And see the vision improved to 6/9. So not all is lost just because the patient has 1/60 vision. We cannot say that there is no vision problems. We should start treating, and over 1 or 2 or 3 injections, we can talk to the patient about prognosis. Can we move to the next case? Indu, Dr. Indu Nair.
Yes, sir.
She's brought in a photocapillaritis 2 labile. Over to you.
Am I visible?
Your presentation you please open your presentation. Yeah, it is visible now.
Okay, am I
Yes. Can you
audible?
present? Yeah, you are audible also. Please present.
At the outset, I would like to thank KSOS for the opportunity. So the case which I am going to present is a photoreceptoritis 2 labile. So this 76-year-old lady who is a known hypertensive, diabetic, hypothyroid, and history of stroke. There is no history of chronic cough, skin lesions, appetite, or weight loss. She presented to us with defective vision of both eyes, left more than right, which was gradual in onset and painless. So best corrected visual acuity was 6 parts in both eye. Intraocular pressure was normal. Anterior segment showed nuclear sclerosis grade 2. There were no AC or ABF cells. Fundus showed posterior vitreous detachment in both eye, and left eye showed some druseness. So we suggested her cataract surgery. And 3 weeks later, she came with vision. She tells that there was history of viral fever 2 weeks back, following which she noticed a vision drop. And at this point, the BCVA of right eye was 612 and left eye was 636. And the eye was quiet and immature cataract was present. And this was a fundus picture at that time. Both eyes showed small placoid yellowish lesions, and left eye showed faint confluent plaque-like lesion in the fovea. So this is the OCT at that time. Right eye showed faint ERM, and left eye there is subretinal hyperreflectivity and thickening of the EZ, and you can also see some focal areas of hyperreflectivity in the outer retinal as well as intraretinal areas. So patient was advised uveitis and vasculitis evaluation, and she was started empirically on topical steroids, planned for angiogram. And when she reviewed for angiogram, she had further vision drop at that time, and BCV of right eye was 636 and left eye was CF at 3 meters. So there was no AAC or ABF cells, and fundus shows increase in vitreous opacities in both eyes. The confluent plaque lesions and the yellowish placoid lesions were present in both eyes. And in left eye, you can also see some old depigmented lesions inferiorly. So this was a IR and the AF image, and there is no characteristic appearance on IR or blue peak autofluorescence image. So OCT at that time in right eye also showed focal hyperretinal areas in the outer retina, and there is mild thickening of EZ. And left eye showed the focal areas decreased, but the confluent band-like hyperreflectivity in the outer retina was persisting. So we went ahead with the FA and ICGA. The FA was unremarkable, but ICGA showed late mottled sort of appearance with hypocyanescent areas. And left eye showed there's mild disc leak in the late phase, as well as and rest of the FA was normal, and ICGA in late phase showed mottled appearance with hypocyanescent areas. So this was the investigations. Uveitis workup was negative. Autoimmune workup was negative. We did a physician evaluation also, and it nothing was seen. And so we had a doubt whether it's inflammation of the photoreceptors. Is it a primary disease? We couldn't see any secondary cause. We started her on oral steroids in view of the vision dropping. So 2 weeks later on steroids, we could see that the vision has improved, and the outer retinal hyperreflectivity has significantly reduced, and there is but EZ rarefaction you can see in both eyes. So 1.5 months after steroids, the vision became 6 parts. The placoid lesions disappeared in the fundus. The eye is quiet, except for EZ rarefaction and some focal areas of hyperreflectivity. So 1 month later, while still on steroids, she came with increased floaters. And vision at that time, right eye was 612 and left eye was 69. Right eye showed few snowballs. And at this time, we could see anterior vitreous phase cells were present. So this was the OCT at that point, again showing EZ rarefaction. So 3 weeks later, she again came with further vision drop with significantly increased vitreous. Right eye was CF 3 meters and left eye was CF 1 meter. And this is the OCT. At this time, you can see posterior vitreous hyperreflective clumps, and there is EZ rarefaction in both eyes. This was a B scan done. There is vitreous opacities are present, but there are no RCS thickening. There is no mass lesion. So these are the points to ponder. Is it a white dot syndrome? There is posterior pole EZ elem involvement with focal overlying lesions. Is it a primary disease or is it a post-viral picture? There is no definite choroidal involvement on ICGA. It's a diffused RP epithelitis or AMN picture, or is it a masquerade as a secondary involvement of photoreceptors? As it is a bilateral involvement, it is patient's age is 76 years. Initial basic workup was negative, and there was initial response to steroid also. No sub-RP disease seen. But we had a doubt, is there an underlying choroidal pattern? So we decided.
Can the others please mute? Thanks.
Okay, so we decided to go ahead with the vitreous biopsy. And this was a vitreous biopsy. There we could see abnormal cells with higher nuclear cytoplasmic ratio, and these were suggestive of lymphoma. So the diagnosis was a primary vitreoretinal lymphoma. So we sent her for a neurology evaluation to rule out CNS lymphomas. MRI was suggestive of lesions of CNS lymphoma. So this turned out to be a case of primary vitreoretinal lymphoma. So my questions to the panel is, how can we, what are the imaging clues with which we can pick the disease up earlier? Because it was responding with steroids and again it worsened. And how can we differentiate between a primary choroidal lymphoma and a vitreoretinal lymphoma based on imaging clues?
Thank you very much, Dr. Indu. You can stop sharing your presentation. Very insightful case.
Because when something is not responding and there is recurrence after steroid tapering, this is one of the DVDs. I think somebody presented, Divya is the, Divya, this some of the OCT findings are suggestive of lymphoma. Somebody presented during the,
from beginning itself, like 76-year-old lady, we wouldn't think of RP epithelitis and other lesions at that point of time. Again, this subretinal lesion, because we have been seeing now, I think I have seen more than 15 cases of VR lymphoma, and this OCT finding is very, very typical from beginning itself. If you see that subretinal band-like lesion material under the retina, in a 76-year-old lady, for me, there is no other differential diagnosis at that point of time. It's lymphoma itself. And again, ICG was also giving the clue that filling defects, and even in your choroid also you can see that round shadows which are with transmitted fluorescence, which like granuloma-like lesions, unlike the vessels which would have caused block fluorescence. So all the findings were there for a lymphoma, I think, and high index of suspicion in an old lady would have given away the diagnosis earlier, I feel.
And it can again show a temporary response with the steroids.
Yeah, it can show, it can mask
and
the
also
findings.
immunosuppression.
Biopsy will be negative
And
when
also
you're on
immunosuppression.
steroid.
Like for example, if you are giving steroids and then the response is not adequate, or if you have recurrence, then you tend to add immunosuppression to the steroid and it will respond. But lymphoma is treated with immunosuppression. Lymphoma is treated with steroids. So it is about the labeling, and it is about how long you have to treat, and obviously the CNS manifestations and stuff like that. Choroidal lymphoma is much less common, I would say. Vitreoretinal lymphoma is what we all see. Yeah.
I think one mistake that we did, I happened to see this patient, is like when the patient came to us primarily, we did have masquerade as one of the DDs. We were thinking of that, but then the normal tendency is to do a peripheral smear, look for abnormal cells, and that turned out to be negative. And so we may get carried away by this finding. So we should have a high index of suspicion, like Dr. Prakash said, that typical OCT appearance of this banded appearance in the outer retina and the subretinal space. We should have gone in for a vitreous biopsy, because now with steroids, if you take a vitreous biopsy, we may end up with not
negative
good report. And so therefore, I think that is one learning lesson. Like Dr. Prakash rightly pointed out, age and this typical OCT appearance, we should have a high index of suspicion, and maybe do an MRI earlier on, which could have actually clinched the diagnosis.
And I think when somebody is on steroids, we have to stop it for at least 2 weeks before planning for a biopsy.
Yeah. And the sample has to be sent within an hour, You should get the pathologist ready for sampling, and it has to be this patient. The sample was sent to Shankar Netralaya. Even though there was a delay in the processing, we could identify abnormal cells.
And also, when we are cutting, we should use very low, cut rates so that we don't damage the cells.
Lyse the cells, yeah.
Okay, let's move to the last case, Dr. Kiran. Thank you, Dr. Indu. Very nice case. Kiran,
can you hear me, sir?
Yes, we can hear you.
Can you see my slides, sir?
Yes. Continue.
Okay. Good evening. Thank you for this opportunity, and sorry for that delay. I'm presenting a 71-year-old female who was earlier treated for CNVM in the right eye and who was lost to follow. Then later she presented with 1/60 vision in the right eye and left eye cataract. So left eye we planned for cataract surgery, and it was an uneventful cataract surgery, and it was done under peribulbar anesthesia. She had no previous history of any inflammation or glaucoma. On post of day one, she had a drop in vision to 2/60. AC was well formed, IOL was well centered. There was no inflammation. IUP was 18. On examination, there was a dome-shaped elevation at the posterior pole with the extensive exudative retinal detachment involving the inferior half of the retina. Superior retina was attached. We considered diagnosis of globe perforation, RRD, ULA fusion, any worsening of inflammatory condition like VKH. And there was no tear, there was no vitritis, there was no hemorrhage. Her axial length was 22.31. We did a B scan, which showed a choroidal elevation with hypoechoic areas posterior to the choroidal elevation and an extensive retinal detachment. Vitreous was clear and the subretinal area was clear. And there was no peripheral choroidal detachment. And we compared the choroidal thickness with the other eye. The peripheral choroidal thickness was less than 2 millimeter in both eyes. And the OCT dome-shaped elevation of the retina, where it appeared as if there's a swelling of the choroid with marked hyporeflectivity of the posterior part of the choroid. Along with that, there is extensive subretinal fluid and
Kiran, you are muted. Kiran, you muted yourself. Please unmute. Kiran, you muted.
Kiran, you are muted.
I'll call him again.
Kiran is not hearing also.
Yeah, he's continuously presenting, I think.
Kiran, you are muted. You can start from the OCT.
Can you hear me, sir?
Yeah, we can hear you, but now you can start from the OCT presentation, that area. Yeah.
Okay.
Little bit more about.
Can you go back?
From there. Yes. From there you can. No,
can you hear me now, sir?
Just a little bit. I mean, next slide. Now we can hear you. You can tell. Kiran, you are again muted. When you are playing the video, you are muted.
Kiran? But it is showing talking, Gopal. What is wrong?
Kiran, video kanikkumbom you are getting.
Tell him that we can see the slides. Only the sound is not coming. Yeah.
Can you hear me, sir?
Yeah.
Okay. The FFA showed pinpoint leaks from the central macula, and ICGA also showed corresponding hypercyanescence from the central macular area. And there was an area of focal leak on the temporal macula, which increased in the size and intensity towards the late phase. Can you hear?
Yeah.
You are audible. Continue.
Okay.
Don't make it
There's
full
an
screen.
area of small RP rip when we ran the OCT along the area of a leak, and right eye showed scarred CNVM. So we arrived at diagnosis of acute posterior UV effusion, and probably due to this increased hydrostatic pressure, there was an RP tear, and which resulted in a serous retinal detachment. Anterior segment, the OCT done was normal in both eyes, and she was closely followed up. At 1 month follow-up, her vision improved to 6/9, and there was complete resolution of the edema. And the choroidal elevation also subsided. And this is the 2-year follow-up. She's maintaining 6 parts vision with no evidence of any recurrence. Thank you.
Can you just show the first day fundus photo?
Okay, sir.
First day fundus photo. There is hemorrhage also, no?
On examination, there was no hemorrhage, sir. No vitreous.
This looks, picture looks
This is a
very
multicolor picture which is showing.
Because
it's
of
a
the
multicolor.
multicolor.
but
No
the
hemorrhage.
lower part, I see it is not hemorrhage.
No hemorrhage.
No, sir. There was an absolute clear view. There was no vitritis. We could see the fundus
No,
clearly.
vitritis. My first and only diagnosis is perforation. Just gone inside and came out.
Yes, sir. That was I thought, we first thought, but the globe was
angiography was the problem, Mahesh. The
angiography you will get. It exudation will cause little fluid around from that area. You can get this sort of punctate hyperfluorescence and all. It's a non-specific thing. But if there was a rip,
why should there be a focal leak?
No, that wherever it has perforated might have been leaking. That area, there's a scar in the post-op picture. Just see that. And where is the rip in the post-op? If there's a rip, there should be a large denuded area with a flat scar. There is no rip in the last picture. It's only a scar in that dot area. I think needle has gone inside and gone.
Not the large rip, that the typical rip that we see, probably micro rip kind of thing.
Micro rip will never cause. Yeah, I don't think. But the last picture is not showing any. I think it is a needle has gone inside and came out. Everything can be described based on that.
Sir, I have another similar case. If you allow, I'll just show an OCT alone.
Can I ask you one thing? I mean, you look at the B scan. So the B scan is not showing entirely serious. No, you showed the B scans.
Yeah, it's hemorrhagic.
Where there is some reflectivity, some echogenicity under the membrane. Can you just go?
I thought it is subretinal hemorrhage actually.
Exactly. That's what
B scan is showing subretinal hemorrhage. That's what I thought.
No, that's under the choroid. That echogenicity is under the choroid.
This echogenicity is under the choroid.
No, that lower part. The second picture under the
I think that is something like an artifact, sir. Because other images.
No, you can't get an artifact like that.
Okay, so there are some differences in opinions. Fine, but all is well that ends well. Kiran has 6/6 vision. What did you do to get that 6/6 vision post-operatively?
Nothing, sir. We just observed.
Very good. Masterly inactivity.
Was the patient on steroids?
No, sir. Other than the topical post-operative medication, we didn't start her on steroids.
Okay.
Even if you look at that OCT, just after the ultrasound, you showed an OCT. If you just look at that OCT, where you show that choroidal elevation, there is also an adjacent PED there.
Yes, sir. And on the edge of the PED, there's a break. I believe that that drip would have.
Slide number 7. Yeah. Just show the slide number 7.
I
Sir,
think that
here,
corresponds to the leak in the FA, right?
yeah. I'll show you the
So you have subretinal. It looks like you have subretinal fibrin there, and
yes,
there
sir.
is large PED there. See this membranes under in the subretinal space.
Was this surgery under peribulbar, Kiran?
It was under peribulbar. It was under peribulbar.
Okay, so
OCT through the
just a
lesions.
needle prick. Yeah. Just a needle prick can cause disruption of blood retinal barrier. No, you can get leak. But my only thing is, if there was a big rip, small rip will not cause this much of change all around. Big rip was there, definitely it would have shown some picture. I mean, in the post-op, 1 year later, you showed the picture. Nothing is there in
if
that.
there was a needle perforation, Dr. Mahesh, if there was a needle perforation, then one, the perforation will be seen. Number two, the hemorrhage would be subretinal hemorrhage, which they are telling it is not a subretinal hemorrhage, it's only clear fluid.
But the B scan is definitely showing subretinal hemorrhage.
No, Mahesh, clinically it is visible. There is no subretinal hemorrhage. It's very clear media.
Maybe, but B scan is having
Mahesh, the FA is not showing anything. The FA is not showing any block fluorescence there. No? It's subretinal.
It is there, no? It is there, no? The lower part.
There is
that
no
area
block fluorescence.
Actually, that just see that what you are
due to
showing.
SRF. That is only due to SRF. Subretinal hemorrhage
That is an SRF, sir.
big blocked fluorescence. It is not like
Anyway,
this.
it is not a big perforation because
an absolute blocked fluorescence.
Okay, so there is some perforation bar rip. Perforation is basically what is iatrogenic. Rip was not iatrogenic. That is the only difference. Finally, there is some tear there or excursion inside, which caused the fluid to come in. And with observation, it came back. But anyway, day 1 post-op cataract surgery patient, uneven cataract surgery 2/60, that poor surgeon would have had a difficult time. All right. So for want of time, let us. Yeah. The last comment.
Acute RP rip after cataract surgery, I think we have had 3 cases at least. But this is the one with the choroidal fluid loculation and shallow exudative area. Other cases were like almost presented as reg RD. I was referred as reg RD for surgery, and we found an RP rip after large RP rip, like what Mahesh told. But this I feel is a variant where you have something like a choroidal loculation and a small RP rip which caused a shallow RD, which again observed. Just to keep in mind that this thing is possible and observation could be an option in these cases.
Is it in the immediate post-op period, post-cataract?
It was on the post-day 1. Post-op day 1.
No, 3 cases which Dr. Prakash was mentioning.
Yeah, it was 2 weeks to immediate cataract to 2 weeks period. Cataract surgery. One is actually a doctor's father from.
Okay, let's not disclose identities. So it had been a wonderful 1 hour and 15 minutes of case discussion. We discussed 6 cases, right from outer retinal pathologies. Kiran, you can stop sharing. Thanks. So right from retinal epithelial issue, which pulled out a syphilis, to oxaluria, to brolucizumab problems, to photo epithelitis, a lot of these different interesting cases. I thank all the panelists and all the speakers. Over to you, Pastor and Dr. Thomas.
Yeah, thank you, Gopal. Actually, this is the first episode only, so we'll be continuing the same webinar with different subspecialties like pediatric ophthalmology, neuro-ophthalmology, etc. And as Gopal said, it was a wonderful session. And thank you all the panelists and the presenters for your valuable time. Over to you, sir, President.
Thank you, Bastian. On behalf of KSOS, let me thank Dr. Gopal for organizing this and Bastian for conceptualizing this idea. This has been a good session. It has been a very beautiful session with all very wonderful cases. Let's hope that this format continues in all specialities, and we'll take it forward. Thank you and have a nice day.
Thank you, sir. Thank you, Gopal. Thank you very much.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Bye. Good night. Good night.